Picture this, it's 3 in the morning. A young woman is wheeled into my resuscitation bay with a gunshot wound to the face. The airway's bleeding, the anatomy's distorted, and she needs a breathing tube. And like yesterday, I do what most of us do in 2026. I reach for the video laryngoscope, hyperangulated blade. I get the camera in, I look up at the screen, and within about 4 seconds, I cannot see a single landmark. The lens is painted red. I have a beautiful, high-definition view of nothing. Cut to the second attempt, a standard Mac blade, direct laryngoscopy, look down at the mouth, intubate, done. Now I tell you the story not to flex about a save, but because it's the exact tension at the heart of today's paper. When does the new technology beat the old technology? And when does the old technology save you from the new? G'day team, and welcome back to Overheard in the Emergency Room. I'm Dr. Cois, evidence nerd, and your guide through the messy, fascinating world of medicine. Today is episode 3 of Overheard Journal Club, the short, punchy series where I take a single paper, break it down, and tell you exactly how it changed the way I practice. We'll go through the PICO framework, we'll go through results, what's good and what's not, and what to do with it on your next shift. And today's paper is one that anyone who manages airways needs to know inside out. Rutzler and colleagues published in JAMA 2024. Video laryngoscopy versus direct laryngoscopy for endotracheal intubation in the operating room, a cluster-randomized clinical trial. Quick personal philosophy before we dive in. Airway management terrifies me, and I mean that in the best possible way. When you really think about what an endotracheal intubation is, you are sedating a patient, then you paralyze them, you take away their respiratory drive, their airway protection, often the only mechanism they have to compensate for whatever metabolic chaos is going on inside their body. And then, and only then, do you actually look at the airway you're about to intubate. That sequence is wild when you think about it. The motto I run on my shifts is simple: be prepared, not scared. And papers like this one are how you stay prepared. Before we go any further, hit the like, subscribe, and the notification bell. The companion blog, full reference list, and links to the paper are all at drcois.com. Right, let's go. So here's the scale of the problem. Across all settings, roughly 8% of intubations require more than one attempt at endotracheal intubation. 8% doesn't sound like much until you remember the consequences of a second attempt. Hypoxemia, hypotension, aspiration, airway trauma, and in the worst case, cardiac arrest. Every additional attempt is a step closer to the cliff's edge. So the question is not academic. It's, can we do something? A piece of kit, a workflow change, anything that drops the multi-attempt rate. Video laryngoscopy was introduced in 2001 and promised exactly that. Instead of operators trying to align 3 anatomical axes, the mouth, pharynx, and larynx, into a single line of view, the camera at the tip of the blade does the work for you. The image comes back to a screen at eye level. In theory, that solves the visualization problem, but the evidence has been genuinely mixed. There's a 2017 ICU trial that found video laryngoscopy didn't improve first-pass success and was actually associated with more severe complications, including cardiac arrest and severe hypoxemia. There's a 2022 Cochrane meta-analysis that found only a small benefit with low certainty evidence. And then there is the large effectiveness trials in trauma and emergency department showing clear video laryngoscopy benefit. So heading into 2024, the question for surgical patients in routine OR practice was still, which device should we be reaching for first? Rutzler and the Cleveland Clinic group set out to answer that. And in a moment, I'll tell you why I think their answer is right and where, in my view, the paper falls short for those of us who don't work in the operating room. Right, let's go through this PICO style: population, intervention, comparator, and outcome. The population was 8,429 surgical procedures in 7,736 adult patients at a single academic medical center in the US, the Cleveland Clinic, between March 2021 and December 2022. These were adults aged 18 or older having cardiac, thoracic, or vascular surgery, elective or emergent, who required a single lumen endotracheal tube for general anesthesia. Median age was 66. 35% were women, 85% were elective. So this is your bread and butter major surgery population, not the chaotic, undifferentiated airway you see in the emergency department, but not exactly low risk either. 81% of these patients were ASA physical status 4. That is, life-threatening systemic illness. Intervention and comparator. This is where the design gets interesting. Two sets of 11 operating rooms were treated as clusters and were randomized on a 1-week rotating basis to perform either video laryngoscopy or direct laryngoscopy for the initial attempt. So every week, half the OR floor was doing one technique and the other half was doing the other. And the next week, they flipped. The video laryngoscope was the glide scope with a hyperangulated blade, usually a size 3 or 4. The direct laryngoscopy comparator was a Macintosh blade of the same size. Stylet use was mandated for video laryngoscopy and left to clinician preference for direct. Most of the intubations were done by residents, fellows, or nurse anaesthetists. Attending anesthesiologists did only about 3% of first attempts, and that matters, which we'll come back to. The outcome. The primary outcome was the number of intubation attempts per surgical procedure. Secondary outcomes were intubation failure, which were defined as the clinician switching to a different laryngoscopy device for any reason or needing more than 3 attempts, and a composite of airway and dental injuries. So here are the numbers, and they are striking. More than one intubation attempt was required in 77 of 4,413 procedures randomized to video laryngoscopy. That's 1.7%. In the direct laryngoscopy group, more than one attempt was required in 306 of 4,016 procedures. That's 7.6%. The estimated proportional odds ratio for the number of intubation attempts was 0.2, with a 95% confidence interval from 0.14 to 0.28. P-value less than 0.001. In English, a patient randomized to video laryngoscopy had roughly 80% higher odds of requiring fewer attempts than a patient randomized to direct. That is a huge effect size. We almost never see relative differences like this in airway literature. The secondary outcome is even more dramatic. Intubation failure, that is, a clinician switching devices or needing more than 3 attempts, occurred in 12 of 4,413 video laryngoscopy procedures. That's 0.27%. With direct laryngoscopy, it was 161 of 4,016. That's 4%. A 15-fold reduction. Absolute risk difference of about 3.7% in favor of video laryngoscopy. The composite of airway and dental injuries, about 1% each group, statistically indistinguishable. That's a reassuring null finding. Video laryngoscopy didn't introduce new harms, which was a real concern from earlier ICU data. So the headline here is clean. In a real-world OR cohort, hyperangulated video laryngoscopy crushed direct laryngoscopy on first pass success and rescue device rates with no signal of increased injury. What's good and what's not? This is the part of Journal Club where you stop being a fanboy and you start being a critic. I love the result of this trial, but loving a result doesn't mean ignoring the design questions. So what's good? 1. The sample size. 8,500 surgical procedures is enormous for an airway trial, and it was stopped at the second interim analysis for efficacy. The effect was so consistent, the Data Monitoring Committee couldn't justify continuing to randomize patients. 2. The cluster crossover design is pragmatic and clever. By flipping the whole OR every week, the investigators reduced selection bias. Clinicians couldn't cherry-pick easy patients for one device, and they got operational adherence that traditional blinded RCTs would kill for. 3. The result is mechanistically coherent. A hyperangulated blade with a camera at the tip should give you a better view of an anterior airway. The Cormack-Lehane grade should improve. First pass success should improve. The data line up with the physiology. 4. It's consistent with the broader literature. A 2018 meta-analysis of video versus direct laryngoscopy outside the operating room, that's emergency departments and ICUs, showed the same direction of effect. A 2022 meta-analysis in the pre-hospital setting found the same thing. The Cleveland Clinic data slot neatly into a converging picture across emergency critical care and now elective OR practice. What's not so good? 1. It was single center. Cleveland Clinic is an exceptional academic institution with deep training programs specialized in cardiothoracic anesthesia and a culture that adopts new technology early. A community hospital in rural Oregon may not see the same effect size with the same operators. 2. The patient population is narrow. Cardiac and thoracic and vascular surgical patients. They're all relatively well fasted, well positioned, well oxygenated, on an operating table with the head of the bed ramped, and frequently with the luxury of a senior attending right there. This is not the airway I'm intubating at 3 in the morning in the resus bay with bodily fluids all over the floor. 3, and this is my biggest issue with this paper. For those of us in emergency medicine and pre-hospital medicine, the video laryngoscope was a hyperangulated blade, not a standard geometry Mac-style video blade. That choice biases the comparison toward video laryngoscopy for difficult anterior airways, but it also means the trial cannot tell us whether the same effect holds when you use standard geometry video blades, which is my preferred tool. 4. Operators were predominantly trainees, residents and nurse anaesthetists. Trainee skill in direct laryngoscopy is on average lower than in video laryngoscopy across many modern training programs, simply because they've had less direct experience. So this trial may also measure an operator skill gradient as much as device performance gradient. If your trainees have done 100 video laryngoscopies and 10 direct ones, the device that wins on first pass success is the one they've practiced more. 5. It was an open label, which by design there's no way to blind a clinician to which blade is in their hand. That introduces the potential for co-intervention bias, particularly for the rescue device secondary outcome. For routine OR intubations, practice changing. For my world, emergency medicine, informative, but not the final word. Right, let's land this episode. Here's how I've actually changed my practice in response to this paper and the broader video laryngoscopy literature. Rule 1, if video laryngoscopy is available, my default first pass tool is a video laryngoscope. Full stop. The data across the OR, ED, ICU and pre-hospital settings now point in the same direction. And the only reason not to default to video is if you don't have access to it. Rule 2, and this is where I diverge from the Cleveland Clinic protocol. I always reach for a standard geometry blade for video laryngoscopy, not hyperangulated. And here's my reasoning. Standard geometry video laryngoscopy gives you optionality. You can look up at the screen and use the video. Or if the camera fails, and it will fail sometimes in the dirty airways we manage in the emergency department, for example, you can just look down at the patient's mouth and perform direct laryngoscopy with the exact same blade. You don't have to switch devices, you've just adjusted your gaze. With a hyperangulated blade, that fallback isn't available. The blade geometry is wrong for direct visualization in the vast majority of cases. So if your camera is contaminated with blood or vomit, you're committed to a device swap. And in the airway I described at the top of this episode, the gunshot wound to the face, a blood-filled airway, that swap cost me an attempt, time and oxygen reserve. Rule 3, bougie ergonomics. I'm a bougie first operator for most of my intubations, based on the bougie meta-analysis that we will discuss on this show. And I've never found a hyperangulated blade to be ergonomic with a bougie. The angle the blade forces the bougie tip into is awkward, and the rigid stylets that hyperangulated systems use don't conform around airway corners the same way the bougie does. Standard geometry video laryngoscopy plus bougie is, for my hands, the optimal setup. Rule 4, and this is the one that I want every resident listening to internalize. Don't let video laryngoscopy erode your direct laryngoscopy skills. I work in a community hospital. Part of my role is responding to hospital-wide codes, often in places without a video laryngoscope immediately available. I'm fortunate that we have a CMAC tower that can be wheeled to a bedside, but in the seconds before that tower arrives, I need to be able to intubate with a Macintosh blade and a head tilt chin lift maneuver. That skill atrophies if you don't use it. So my personal practice and what I encourage my trainees to do is to set up video laryngoscopy, but on a lower risk airways, deliberately perform direct view first. Look down, not up. If you get a Cormac-Lehane grade view 1 or 2, you intubate from there. If you don't, you look up at the screen and convert to video. You get the safety net of video laryngoscopy without losing the muscle memory of direct. And let me be honest with you, this is the part of the paper that didn't get framed the way I'd frame it for my learners. Rootsner and colleagues showed that video laryngoscopy reduces multiple attempts at intubation in the OR. And I agree, but the lesson I want my residents to take is broader. Pick a tool, master a setup, and build redundancy into your workflow so that the day the technology fails, you still have a way to save yourself. So here are your 3 takeaways from today. 1. In adults undergoing elective or emergent cardiac, thoracic, or vascular surgery, hyperangulated video laryngoscopy reduces the number of intubation attempts compared with direct laryngoscopy. Multiple attempts dropped from 7.6% to 1.7%. Device switch rescue dropped from 4% to 0.27%. Airway injury was unchanged. The signal is large, consistent with biology, and consistent with literature in other settings like the ED, ICU, and pre-hospital. 2. Default to video laryngoscopy if you have access, but choose your blade geometry deliberately. For emergency airways where contamination is likely, a standard geometry video blade gives you the option to convert seamlessly to direct laryngoscopy if your camera is compromised. A hyperangulated blade doesn't do this. 3. Don't let the new tech rob you of the old skill. Practice direct laryngoscopy under the safety of the video setup. Eyes down on lower risk airways, eyes up when you need the camera. That's how you stay prepared, not scared. If you got value from this, please like, subscribe, and hit the notification bell. Drop a comment with the next paper you'd like me to break down on Overheard Journal Club. I have a long list, but listener requests always jump the queue. And share this episode with the resident, the medical student, or the curious patient in your life who deserves a better explanation of why airway management is a craft, not just a checklist. Head over to drcois.com for the full companion blog, reference list, and links to the paper. I'm Dr. Cois. Let's chase less bad days and more good decades together. And we'll see you next time, and hopefully not in my emergency department.